there is a further 80% increase above non-pregnant values. Stroke volume increases by 25%, and this is noticed from 5 to 8 weeks. The heart rate increases by 25%. A whole 15% increase is actually noticed by the end of the first trimester. The mean arterial pressure actually decreases by 15 millimeters of mercury and is found to be normal by the second trimester. This is seen by the effects of dilation in the peripheral vessels. And then the systemic vascular response and peripheral vascular response decreased by 21 and 34% respectively. Central venous pressure, there is no change. Uterine blood flow increases by 40% by term. The CVS examination reveals a shift of the apex to the left and petaled. The third half sound can be heard by the second trimester, and the fourth half sound could actually be elicited in up to 16% of pregnant patients. Due to the increased blood flow, a grade 1 to grade 2 systolic murmur can be heard. Chest X-rays that are done show enlarged cardiac stereo. For hematologic changes, the plasma volume increases by 15% in the first trimester and a whooping 55% by the second trimester. But the red cell volume does not increase accordingly, with only 30% at term. The cell volume increases by 45%, and hemoglobin concentration decreases by 15% in the mid-gestation. The platelet count does not change or is reduced in specific conditions that can be associated with pregnancy. The PT and PTK decrease, while the fibrinogen, fibrinolysis, and all the clotting factors increase. Plasma volume increases to supply placenta and maternal organs, the uterus, the kidneys, the breast, and the skin. There's a relative and dilutional anemia. Due to slower increase in red cell mass relative to plasma volume. Hemoglobin levels of 10.5 to 11 grams per deciliter are found to be acceptable in pregnant women. There's increased platelet activation and coagulation factors, which results in hypercoagulable states in pregnant women, predisposing them to thrombotic events like DVT and pulmonary embolism. Antepartum maternal deaths from pulmonary embolism mostly occur in the first trimester. The increased platelet consumption is compensated by increased production, therefore resulting in what we've seen before, which is no change in platelet count. Thrombocytopenia can actually be found in 0.9% of normal pregnant patients. And it's usually, when it's seen, it's usually associated with preeclampsia or CONT syndrome. Pulmonary and respiratory changes include an increase in minute volume of up to 50%, alveolar ventilation up to 70%. The tidal volume also increases by about 40%. The oxygen consumption increases by 20%, and the respiratory rate increases by 15%. There's no change in bed space or lung compliance, and there's also no change in vital capacity. The residual volume and functional residual capacity can make there be a decrease in this two by up to 20%, and the first expiratory volume in 1 second also does not change. Now, the capillary engorgement and airway edema can be seen in pregnant women, and this makes the mucosa friable, leading to bleeding or manipulation of the airway, or when there is trauma to the airway. Airway changes that have been described in the presence of also enlarged breast contributes to a difficult laryngoscopy and possibly a difficult intubation. A combination of increase in oxygen consumption and decrease in functional residual capacity makes the pregnant woman prone to hypoxia and rapid desaturation during active periods. They reduce functional airway closure in 50% of pregnant women who are supine at term. Now, this is a diagram showing a summary of the pulmonary changes. These changes could be anatomic effects and then functional effects. For the functional effects, there's increased respiratory drive resulting in reduced PSO2 from the effect of the progesterone on the medullary center. Then there's also a minimal change in total lung capacity, but there's increased tidal volume from the then there's also a reduced functional residual capacity predominantly caused by a reduction in respiratory reserve volume. Here, there's still the diaphragmatic function is preserved. But anatomically, the diaphragm is elevated and there's a widened subcostal angle. Now, due to the increasing demands of the fetus in the womb, there's increased oxygen consumption and CO2 production. The enlarged uterus causes the widening of subcostal angle and elevated diaphragm. And of course, the widened anterior, posterior, and transverse diameters also occur in the pregnant woman. Now, an arterial blood gas, comparing the results in a pregnant woman and a non-pregnant woman. Here we can see that there's an increase in the pH and a PaO2 and reduction in the PaCO2. This picture generally is that of a chronic alkalosis, respiratory alkalosis. The increased metabolic rate in mother and fetus leads to increased oxygen consumption and carbon dioxide production, which should result in persistent hypoxia and mild respiratory acidosis. But instead, what we see is the mother hyperventilates, loss of a lot of carbon dioxide, leading to mild respiratory alkalosis with complete renal compensation and normal pH. These effects are that of progesterone in the medullary respiratory center. In the GIT, stomach is upwardly displaced, shifting the gastroesophageal junction and reducing the tone of the lower esophageal sphincter and increasing the risk for reflux. The gravid uterus causes an increased intragastric pressure and lowers the barrier pressure, which is the difference between the intragastric pressure and the pressure on the lower esophageal sphincter. This predisposes the pregnant patient to regurgitation and aspiration. Gastric emptying and aspirating are little changed by pregnancy, but they are markedly slowed in established labor, which might return to normal by 48 hours postpartum. Since gastric motility and emptying time may be prolonged, all pregnant women, irrespective, should be given pre-aspiration prophylaxis. It is worthy of note that trauma and IV opioids may further prolong this time. The renal blood flow and glomerular filtration and creatinine clearance are all increased in pregnancy, but the blood urinary nitrogen is reduced. Creatinine is also reduced. Glucosuria of up to 10 mg per kilo and proteinuria up to 300 mg per kilo are considered normal in pregnancy states. The progesterone causes dilated renal pelvises, pelvis, and ureters from 12 weeks of gestation, and this results in urinary stasis that contribute to frequent urinary tract infection in pregnancy. The central nervous system, one can realize there that the progesterone level in plasma and CSF actually increases by 10 to 20-fold, even by the third trimester. This progesterone is sedating, potentiates the effects of collateral anesthetic agents, and it is the mark can be reduced by up to 25 to 40% in pregnant patients. The increase in sensitivity to local anesthetic agents in spinal and epidural anesthesia necessitates a reduction in dose of up to 30% in this category of patients. In the liver, there is no change in size, morphology, or blood flow, but all the liver enzymes are increased. And then the gallbladder emptying is slow, causing concentration of the bile and predisposing the pregnant patient to gallstone formation. Increase in plasma albumin concentration leads to increase in free fraction of protein-bound drugs. So this increase as albumin levels decrease. The active drug, the active component of these drugs that are protein-bound become increased in levels in the blood. The total protein levels also decrease as also maternal colloid osmotic pressure. The plasma cholesterol concentration decreases by 25% before delivery and 33% by third postpartum day. This is not clinically significant as it's countered by increase in volume of distribution. So we do not need to worry about using succinylcholine in this group of patients. The intercava compression syndrome leads to compression of the inferior vena cava by gravid uterus, causing hypotension and tachycardia. Aortic compression reduces uterine and placental blood flow, leading to fetal distress. This diagram shows a summary of all we've been discussing, and worthy of note is the fact that the changes in oxidative liver enzymes such as cytochrome P450 cause some this physiological change causes altered drug pharmacokinetics. The physiological changes during pregnancy affects and the effects on drug disposition are outlined in this table. The delayed gastric emptying time and increased gastric rate alters drug availability and delayed time to peak levels after oral administration. The increased cardiac output causes increased hepatic blood flow, increasing elimination of drugs that are eliminated through the liver. Increased
Diomi, are you having any challenges there?
The video is playing. Mr. Ediomi, we can't get the audio, just the screen we are seeing. Thank you.
The postpartum period. So patients with pulmonary hypertension and stenotic valvular lesions are at risk at this time. The functional residual capacity and residual volume rapidly return to normal in the postpartum period, and pulmonary changes due to mechanical compression since the baby has been removed, the gravid uterus and all the effects return to normal. Dilutional anemia results and hematocrit returns to normal by 4 weeks due to postpartum diuresis. Mechanical effects of the gravid uterus on GIT results within 2 to 3 days, but gastric emptying takes a few more several weeks due to the slow decrease in progesterone levels. Creatinine, GFR, and BUN normally come back to normal values within 3 weeks. In summary, important physiologic alterations in pregnancy include increase in cardiac output, heart rate, plasma volume, minute ventilation, and oxygen consumption. There's decreased systemic vascular resistance, there's dilutional anemia, there's decrease in functional residual capacity, and the patient is predisposed to a hypercoagulable state. There's altered drug pharmacokinetics as a result of increase in this volume of distribution and fat distribution, increase in fat in these patients as well. Pregnant patients can pose airway management problems, including airway edema, large breast, and full stomach. Pregnant patients are sensitive to both volatile and local anesthetic agents. These are my references. So going back to our question, pregnancy should not be viewed as a disease state. It's a normal adaptation to the growing fetus within the woman. As we can see here, these are Beyonce and Serena Williams, who carried their pregnancies even during their career, and they didn't have to stay in the hospital through that time. So these normal adaptations can be done in in patients, and they will live their normal lives even though they are pregnant. Thank you for listening. Please send your questions after the end of this presentation. Thank you very much.
Should I proceed with the second recording?
Yes, please proceed with the second presentation. Thank you.
Good evening, everybody. My second presentation today is on anesthesia for non-obstetric surgery during pregnancy. I'll be making this presentation using the following outline. Introduction, indications for surgery, goals of anesthetic management, anesthetic considerations for both the mother and fetus, recommendations, principles of anesthetic management, special considerations, and then I'll conclude. Anesthetists encounter pregnant women not only for obstetric analgesia and anesthesia, which could be general anesthetic or regional anesthesia. Advances in fetal surgery has further widened the scope of anesthesia for non-obstetric surgeries. The incidence of these surgeries can be has been seen to be between 1 to 2%. And in a study done in just by some obstetricians, they found out that they had an incidence of 4.6 per 1,000 births. Acute appendicitis in the same study, acute appendicitis was seen to be the commonest indication for surgery in these pregnant women, and it accounted for 86% of the study population. Associated, these studies can have associated increase in fetal loss and premature delivery. Now, this increase in fetal loss and premature delivery, is it as a result of the underlying pathology or anesthesia or surgery? It has been found that that most probably is as a result of the underlying pathology and not anesthesia or surgery. Now, despite advances in perinatal, perioperative care and anesthesiology, emergency non-obstetric surgery in particular is still an important cause of poor fetal outcome and maternal mortality. A thorough understanding of the physiological and pharmacological adaptations in pregnancy is essential to ensure maternal safety. In a study by Mazi, it was found that 42% of these surgeries were done in the first trimester, while second trimester had 35%, and the lowest number of surgeries were done in the third trimester, which actually is when the fetus is viable, and there's no question of viability. Now, some indications include some that are pregnancy-related, like cervical sacrilege, ovarian torsion, and surgery on the fetus that the pregnant woman is carrying. Some that the others that are not related to pregnancy, like we said, acute appendicitis being the commonest. Then we have acute polycystitis, bowel obstruction, trauma, malignancies like breast cancer, cardiac procedures, and neurological procedures. Now, what are the goals of anesthetic management? This includes to optimize and maintain normal maternal physiology, because this is important in ensuring that the fetus is not, and the mother's physiology is maintained, so that her life is not under any further complication as a result of anesthesia, and then the fetus is also safe. To optimize and maintain uteroplacental blood flow and oxygen delivery, to avoid unwanted drug effects, that the drugs that might be given during anesthesia, we don't want any unwanted drug effects on the fetus, to avoid stimulating the myometrium, because pain and even this surgery that is being done, most of these interventions have effects. To avoid awareness during general anesthesia, as this would increase the level of catecholamines and jeopardize the fetus and even increase uterine contraction. And then use of regional anesthesia wherever possible. Now, the American College of Obstetrician and Gynecology says, regardless of the trimester, pregnant women should not be denied indicated surgery. So the pregnant woman takes first place and should never be denied on the account of her pregnancy when she needs surgery. Now, elective surgery, if it's an elective surgery, it should be postponed till after delivery. If it's not urgent, then one can further move it forward to the mid-trimester, where the risk of preterm contractions and spontaneous abortion is less. And then the choice of drugs and anesthetic technique should be guided by maternal indication and the site of surgery. There's no one size fits all. So the woman should be properly assessed and then given the appropriate anesthetic drugs and anesthetic technique. Resuscitation, if required, should be vigorous. As we know, trauma is one of the indications for non-obstetric surgery in pregnant women. So we should follow the guidelines of advanced life support and ACLS. Then a 15-degree left lateral tilt should be applied from 20 weeks to avoid sudden hypotension even when resuscitating this patient. Pre-oxygenation, rapid sequence IV induction and intubation, and then effective cricot should be maintained in caring for this patient and accessing their airway during surgery or for resuscitation. Now, 100% oxygen should be given for 3 to 5 minutes. When you want to do a rapid sequence induction, you should still apply the principles that apply in non-pregnant patients with some adaptations in consideration of the uterus, the enlarged uterus that might pose some extra complications. So 100% oxygen should be given for 3 to 5 minutes, as we're aware there's reduction in functional residual capacity. So this would help for the periods of apnea that might occur during intubation. Thiopentone 5 milligrams per kg can be used, and then suxamethonium 1.5 milligrams per kg. Now, propofol can also be given in titrated doses, and rocuronium is an alternative if sugar madex is available. Then the laryngeal mask airway can be used in cases of failed intubation, and it has been shown to use to ventilate safely and successfully in reverse trilingual position for short periods. The second generation supraglottic airway devices like LMA Pro can also be used in carefully selected patients. Careful patient monitoring positioning to avoid profound hemodynamic instability is very, very important in this group of patients. Increased sensitivity to volatile anesthetic agents, as we have known, there's increased mark. So uterine, these volatile agents can cause uterine artery dilatation, increase in uterine blood flow, countered by decreased maternal arterial pressure and cardiac output. There's so a higher concentration occurs, and then so this should be avoided. Positive pressure ventilation should be carefully done while monitoring the end-tidal carbon dioxide to avoid hyperventilation that might result in hypocarbia and result in compromising uteroplacental blood flow as a result of vasoconstriction. We need to maintain adequate oxygenation so that fetal oxygen delivery can be adequate. Then patients should be extubated fully awake when protective airway reflexes have been restored. In the fetus, some considerations should also be taken. Now, the drugs that are given during administering anesthesia to these patients, a lot has been said about teratogenicity and even the effects of maternal drugs, the other drugs given to the mother during this period of pregnancy. Now, these are the issues that arise in direct effects. But indirect effects, this relate to adequacy of uteroplacental circulation and oxygen delivery, which can be compromised, like we have said in our previous slide, by maternal hypotension. This can result for sympathetic blockade, aortocaval compression or hemorrhage in the woman, and then vasoconstriction of uteroplacental vessels that can arise from hypocarbia, alpha-adrenergic drugs like adrenaline, dopamine, and other catecholamines, or maternal hypoxemia from any cause during the perioperative period. Now, fetal cardiovascular and central nervous system depression can also occur from transplacental transfer of anesthetic agents. Now, talking about teratogenicity of anesthetic agents, what is a teratogen? It's a substance that causes increase of a particular defect in a fetus that cannot be attributed to chance. So, a teratogen has to come at a particular time to be said to have caused a change or a defect in the fetus that is growing in the pregnant woman. So timing is timing of exposure with respect to the development of the child. Was it in the first trimester, second trimester, or third trimester? We all know that organogenesis and all these structural defects usually happen within the first 12 weeks. And then what's the route of administration? This is very important. Is it a route that would not cause it to have a systemic effect on the patient? If this is the issue, then it cannot be said to have caused teratogenicity. Then anesthesia affects intra and intercellular signaling. So generally, anesthetic agents have been said to do that, and cellular mitosis and DNA synthesis. All anesthetic agents are potentially teratogenic, with emphasis on the word potentially. So no anesthetic agents, with all the various studies that have been done in research has been done in animal models. So, and any attempt on human pregnant patients would be unethical. So we cannot conclusively say that all these anesthetic agents that have been tested in rats and animal models and haven't caused some congenital anomalies to be attributed to the same thing to be able to cause the same thing in human subjects. So no anesthetic agent has been proven to be clearly hazardous to the fetus. Now, sufficient, also in talking about the issue, sufficient dose for a substantial period at a critical development time, which I said is between the day 11, day 15 and day 19. So anything, usually any surgery that is not done within that time, and then the dose that is administered is usually a start dose or a one dose. It's not a protracted dose that is used for a substantial period. So clearly, this cannot be demonstrated to be teratogenic. What are the other perspectives that we need to think about in thinking of anesthetic agents being teratogenic? And now, we need to remember that there's a background incidence of congenital anomalies in humans that is about 3%, even in subjects that have never had anesthesia before. So these physiological derangements too can, in the mother or in the perioperative period, like hypoxemia, hypercarbia, or stress and hypotension, may be teratogenic and could have occurred even without surgery or during any time in the pregnant woman period, pre-operatively or during anesthesia. Now, after the 13th week, effects are growth retardation or functional rather than gross structural effects. So the risk of abortion, growth restriction, low birth weight and very low birth weight are attributable to patient's primary disease and surgical procedure, but definitely not anesthesia. Nitrous oxide has been implicated in a lot of papers and have been studied. It's said to inhibit methionine synthesis and DNA synthesis. But like I said earlier, these studies were done in animal models, and high doses for prolonged periods were given to these animal models, which are not encountered in clinical studies. Rarely, nitrous oxide is rarely indicated in anesthetic care of pregnant women now, so because there are definitely alternatives. Now, the other thing that has been implicated as a major cause is benzodiazepines that have been included in cleft palate and cardiac anomalies, but recent studies have countered this association. Now, what are our recommendations? Multidisciplinary approach to the care of pregnant women presenting for non-obstetric surgery must involve the obstetrical team, surgeons, anesthetists, neonatologists, or peri-neonatologists, and nurses. Postponing purely elective surgeries have been recommended till after delivery, and deferring urgent surgery, if possible, until after the first trimester of pregnancy, like I said earlier. Then we can go ahead with emergent surgery after informing the patient about possible risks, obtaining informed consent, after explaining possible risks to the fetus, and taking precautions to safeguard well-being of both the mother and the fetus. Also, during the third trimester, delivery by C-section before major surgery has been advocated. For example, if a woman comes in the third trimester for an urgent surgery, or a surgery that is not emergent but is urgent, you might want to delay by 48 hours and use steroids to cause fetal lung maturation, and then have a C-section, and then go ahead with the major surgery, as this will reduce the risk both to the mother and the fetus. Now, this is an algorithm showing decision-making process for non-obstetric surgery during pregnancy. When you get the pregnant surgical patient, you need to ascertain, is this surgery an elective? Is it an essential surgery, or what we call urgent surgery? And then, is it an emergent surgery? If it's elective, please delay until the delivery of the child as much as you can. If it is essential surgery, then the first you want to know is, are you in the first trimester or are you in the second or third trimester? If you are in the first trimester, you need to decide if no risk or minimal increased risk to mother, consider delaying until mid-gestation. Now, if greater than minimal increased risk to mother, you need to proceed with the surgery as recommended by the ACOG. Now, if you are in the second or third trimester, you need to decide also if there's minimal or increased risk to mother, and you might want to further delay that surgery. If it's in the second trimester, you might want to take it on to the third trimester. If it's in the third trimester, you might want to wait till you know that there is long maturation. Then, if it's an emergent surgery, you need to proceed immediately with optimal anesthetic for mother, modified by considerations for the maternal physiologic changes and fetal well-being. The consults should be sent to the perinatologist or an obstetrician, and then pre-operative and post-operative fetal and uterine, peri-operative and post-operative fetal and uterine monitoring will be useful. Now, what are the principles of anesthetic management? We will discuss perioperative preparation, conduct of anesthesia, fetal monitoring, uterine monitoring, recovery, and post-operative care. Now, the preoperative preparation should be done in conjunction with obstetricians and neonatologists. And we need to evaluate, like the non-pregnant patient, do a full evaluation of taking your history and doing a full physical examination. The laboratory investigation and other investigations ordered should be as indicated by patients' comorbidities and proposed surgery. Symptoms and signs of cardiac disease may be present, like dyspnea, heart murmurs, and peripheral edema. You need to know, have that at the back of your mind, that Some of these signs may be common during normal pregnancy. Then ECG changes in pregnancy include left axis deviation, premature beats, non-specific ST and T wave changes, not necessarily as a result of cardiac pathology. Then protect fetus if radiological investigations are required. Now, prepare for difficult intubation and thromboembolism. Like we have said in the first lecture, pregnancy is a hypercoagulable state. So from the get-go, you need to prepare for as a prophylactic measures for DVT and PE, and also prepare your difficult airway part ahead of time. Then aspiration prophylaxis should be provided. So, like I said, recent gastric hernia has been shown to be normal in pregnancy till the onset of labor. But for all pregnant women, you should prepare should give them as prophylaxis. The risk of aspiration remains even until the effect of progesterone causes reduced gastric barrier pressure and low esophageal tone, so from 16 weeks gestation. So from that period, the risk of aspiration remains. So access for additional risk for assess for additional risk for regurgitation and aspiration. So does the patient have a history of active reflux? Is the patient obese? This will be added. These are added risk factors for regurgitation and aspiration. Then of course, you want to, if it's not an emergent surgery, you want to ensure that the patient is fasted for 6 to 8 hours for solids, and then you book and cross-match blood for all major surgeries. Now, prophylactic glucocorticoids for 24 to 48 hours before surgery for patients that are within that period of 24 to 34 weeks estimated gestational age should be given for fetal lung maturation, and it should be avoided. This should be avoided in patients with systemic infection. Prophylactic tocolytics. Their benefits have been queried as they are not without complications or adverse effects. So it's important that you know that you need to minimize uterine manipulations throughout the period of the preparation and even the surgery time. You minimize uterine manipulations in order not to further cause uterine contractions that will lead to premature contractions and possible preterm birth. Then tocolytics include beta-2 agonists like UTERINE that may cause tachycardia. So these are some of the issues that we have with tocolytics. Magnesium sulfate potentiates the effects of non-deprovising neuromuscular blockers. Some others that have less side effects include nifedipine and atosibam. Now, in the conduct of anesthesia, there is no technique that has been shown to be superior. It all depends on the condition of the patient and the surgical intervention that is required at the site of the surgery. So regional anesthesia, though, minimizes fetal drug exposure. Airway management is simplified, or you don't need to instrument the airway. Blood loss may be less, and then because the volatile agents causing uterine muscle relaxation is not involved here. Then overall risk to mother and fetus is much less when you do regional anesthesia. Largest risk of regional anesthesia is hypotension due to sympathetic nerve block. So attention to maternal fluid volume and blood pressure should be very, very well done. After 6 to 8 weeks gestation, cardiac, hemodynamic, and respiratory, metabolic, and pharmacologic parameters are considerably altered. This should always be at the back of your mind. Then increase in minute ventilation, oxygen consumption, and the reduction in oxygen reserve as a result of the reduction in FRC and residual volume predisposes every pregnant woman to become hypoxic quickly. So we need to give supplemental oxygen during every vulnerable period. The normal hyperventilation in pregnancy results in an end-tidal carbon dioxide of 30 to 34 millimeters of mercury. And one needs to maintain this throughout the period, the perioperative. Is the one thing or technique or intervention that has been shown to be effective. Wedding or manual displacement can only decrease this. It's not totally effective. And in patients that are symptomatic for hypotension, further that left lateral tilt might need to be increased further. Then caval compression leads to epidural venous plexus engorgement and increased risk of IV injection during regional block. So you need to also reduce the volume of the LA given as the space volume is reduced. Then thromboprophylaxis, like we had said earlier, to the incidence of thromboembolic complications is 5 times higher in this category of patients. During the 3rd trimester, C-section by regional can be done, then converted to GA for definitive surgery. Caution should be given because the uterus also still needs to be contracted to avoid excessive bleeding. But this is good because it further helps the management in the mother and even less complications for the fetus. Now, for fetal monitoring, this has to be done during the time of the surgery. Now, this can be done from 24 to 26 weeks because it's supposed to be done when the fetus is perceived to be viable. Now, in Nigeria today, in worldwide, it's known to be in advanced countries, known to be 24 to 26 weeks. But in Nigeria, the acceptable time is still 28 weeks. Even though reports from some studies in Nigeria have shown that preterm fetuses that were delivered at 26 to 27 weeks survived. In a retrospective review at the National Hospital, they studied 305 preterm babies, and 53.8%, they realized their results showed a 53.8% survival rate in patients at GA of 26 weeks. Now, challenges with obese women or during abdominal surgery. Fetal monitoring gives us some challenges with obese women or during abdominal surgery for obvious reasons, because access during abdominal surgery is reduced, and of course in obese women the sounds may be blotted a bit because of the fat between the baby and then the device. Now, the volatile agents can cause reduced fetal heart variability, and then this shows fetal hypoxemia. Fetal monitoring requires skilled interpretation and obstetrician with a plan in case of fetal distress. There's no point saying you are monitoring the fetal heart when there is nobody that is qualified to deliver the baby in case this is indicated even during the surgery. Now, not only should the obstetrician be there, he should also be willing to carry out this procedure at such a time as that. Then ketamine increases uterine tone, so it should be avoided in early pregnancy. Intraoperative fetal monitoring should be individualized, as it's fraught with, it requires skill, and it might be fraught with a lot of challenges. Now, the guidelines by the ACOG says that if fetus is considered viable, you need to ascertain fetal heart pre and post-op by Doppler. The minimum fetal monitoring that should be applied is simultaneous electronic fetal heart rate and uterine contraction pre and post-op. Then intraoperative electronic monitoring may be appropriate if it is physically possible. In other words, the site is accessible and does not interfere with the surgery that is being done. The healthcare provider with skills in obstetric surgery is available and willing to intervene if required. Woman has given consent, informed consent to emergencies for emergency C-section, and nature of surgery will allow the safe interruption of obstruction of the procedure to provide access for an emergency CS. Now, this is a diagram or a picture showing the application of the transducers for fetal maternal monitoring. Now, this shows one that's internal fetal monitoring that will go through the vagina and the cervix, and the probe, you can see a probe there for fetal scalp electrode is applied to the head of the baby. These require a lot of skill, and then there's the intrauterine pressure catheter there. So it monitors internal contraction of the uterus. Then there's the one that is the external fetal monitor that we all are used to, and the transducer for sensing uterine contraction is there, while the transducer for monitoring fetal heart rate is there. So the contractions are monitored, the uterus is there, the fetal heart is also monitored. Now also this is just a picture that shows the same thing, but monitoring of fetal heart from 18 to 22 weeks and heart rate variability from 25 weeks onward requires a skilled interpretation. Difficulty in continuous monitoring and interpretation in both baseline fetal heart rate and heart rate variability. There's difficulty when it's a continuous monitoring. And then cardiotopography, CTG monitoring can be used in viable fetus. Then monitoring enables optimization of maternal condition in signs of fetal compromise. So when this surgery is being done, and this can only be used where the abdomen is not where it's being operated, where if the site of the operation is not the abdomen, or at least where you apply your probes are not near where they're working, then when you see any changes that show that there's either contraction or there's compromise to the fetus as monitored by the fetal heart rate, you can respond appropriately. To monitor the uterine contractions, like we said, we've seen the external topo dynamometer, and it can be placed outside the surgical field. It helps to address fluid and other pharmacologic therapy to optimize maternal hemodynamics, and also involve perinatologists of the obstetrician as in the interpretation of these results. Then especially useful post-op, as post-op analgesia may mask mild early uterine contractions. Now, recovery from anesthesia, it requires close monitoring, especially airway and respiratory system, as the patients, pregnant patients are prone to hypoventilation and airway obstruction, especially when opioid analgesics are used. Then prepare for emergence, extubation, and recovery to avoid complications at all times. The post-operative management of these patients will include providing adequate analgesia. Pain can increase the risk of premature labor, so it should be avoided. Consider regional nerve and plexus blocks, epidural analgesia, reduce risk of opioid-induced hypoventilation. So when you use those nerve blocks, they tend to scare opioids. Then you don't need to give the patient opioids, so you reduce the risk of opioid-induced hypoventilation. Then the transversus abdominis plane block is an alternative to epidural analgesia when it is, especially when it is a continuous block. So the downside is it only blocks the somatic component of pain and leaves out the visceral component. The epidural analgesia covers both somatic and visceral pain. But in studies have shown that continuous tap block, when compared to epidural analgesia, there is no difference in pain scores or the pain scores over time, and opioid requirements. Now, opioids can be used as required, with consideration not to tip the patients to hypoventilation. Then paracetamol is a choice analgesic for mild to moderate pain. Now, considering NSAIDs, they should be avoided, especially after 32 weeks gestational age, as they lead to premature closure of fetal ductus arteriosus if given for greater than 48 hours. Also, oligohydramnios, they can lead to oligohydramnios and reduce fetal renal function. And they can inhibit uterine contraction, though this might be advantageous, as we know indomethacin has been used in the second and early third trimesters to reduce, to inhibit uterine contraction. So in the post-op period, part of the management includes continuous close maternal and fetal monitoring and avoiding triggers of uterine contraction. Now, special procedures that we need to talk about include laparoscopy, cardiac surgery, neurosurgery, and fetal surgeries. Now, pregnancy, for laparoscopy, pregnancy is no longer a contraindication to laparoscopy, and safe. It's been seen to be safe during any trimester. Advantages include less fetal exposure to toxic agents, smaller incision, less pain, more rapid recovery, and early mobilization. So the carbon dioxide pneumoperitoneum actually increases risk of hypoxemia, hypercarbia, and hypotension. So one needs to monitor fetal and uterine status, especially you need to ensure that you have an enteral carbon dioxide monitor and maternal arterial blood gas. Then in doing a laparoscopy, the open technique is used to enter the abdomen. And thereafter, you can use the other things to make a smaller incision rather than a full open technique to the surgical, to obtain a surgical abscess. Then we don't use tocolytics prophylactically. So one needs to consider where there is evidence of preterm labor. So because of the disadvantages of tocolytics, they should not be used during laparoscopy prophylactically and only considered when there's evidence of preterm labor in these patients. For cardiac surgery, during pregnancy, blood volume and cardiac output may increase up to 30 to 50%. So patients come down with severe decompensation. So what are the indications, particularly for surgical treatments in this category of patients? This includes severe mitral and aortic valvular obstruction. So percutaneous balloon valvuloplasty seems a better alternative than surgical repair because there's less fetal and neonatal mortality in this situation. Then the cardiopulmonary bypass particularly becomes very challenging in the pregnant woman because it increases the perioperative weeks, especially for fetus, due to non-pulsatile perfusion that occurs with the cardiopulmonary bypass. There's inadequate perfusion pressures, inadequate pump flow, embolic phenomena to the uteroplacental bed, and release of renin and catecholamines. But how can we, during this time, you need to do intraoperative fetal monitoring, and it's particularly indicated in cardiac surgery due to those complications that can arise and further predispose the fetus to compromise. Then, so this will decrease high fetal mortality rate. What are the recommendations when you're doing a cardiopulmonary bypass? You need to increase the pump flow to greater than 2.5 liters per minute per meter squared. Then perfusion pressures should also be above 70 millimeters of mercury, and maintain maternal hematocrit to greater than 28%. Now, for neurosurgery, it's found that hemorrhage from intracranial aneurysm and arteriovenous malformation is actually not uncommon in pregnancy, unfortunately. So there's increased risk in hypertensive conditions of pregnancy and associated risk factors. So this also further predisposes the patient to intracranial hemorrhage. So controlled hypotension, hypothermia, hyperventilation, and diuresis should be done with caution because these are normal techniques that are used during neurosurgery, but they should be done with caution in pregnant women. So high-dose volatile agents, sodium nitroprusside or nitroglycerin, all have potential adverse effects and decrease uteroplacental blood flow. All cause the placenta and can be post-fetal hypotension. So caution should be exercised when using these things in these agents in pregnant women. Extreme hyperventilation to give you less than 3.3 kilopascals should be avoided. So this can cause uterine artery vasoconstriction, and fetal heart rate is a useful monitor to adjust ventilation accordingly. Then osmotic loop diuretics are usually used to shrink the brain. This can cause significant negative fluid shift. So low dose mannitol of 0.25 to 0.5 milligram per kg is recommended in this patient. Now, fetal surgery. This is a rapidly developing frontier in medicine. The first success was achieved in 1983, and it has come a long way with the increasing number of centers, although they are still done in specialized centers all over the world. But increasing number of people are getting this skill, and anesthetists are having to come in to assist in these surgeries. Surgery on the fetus while in utero to address life-threatening and non-life-threatening conditions in the fetus. So it's done in limited number of specialist centers worldwide. I don't even know of any in Nigeria. And minimal access surgery development has also helped to address the issues of preterm labor. So minimal access is also applied during these surgeries to further minimize the complications that can arise, like preterm labor and premature rupture of membranes associated with open surgery. There are different types. There's the minimally invasive one, like I just said, mid-gestation open procedures, or exit, like ex-utero intrapartum procedures. So some of these procedures are done just at the time of delivery, before the baby, as the baby is born, these procedures are done, or even mid-gestation before the baby comes out, they are done. And of course, the minimally invasive procedures. Now, what is usually done is an incision is made on the abdomen of the woman, and there are a lot of specialists that are involved. The perinatologist are there, the pediatric surgeon is there who specializes in fetal surgeries. The obstetrician is also available in cases where the neurology, it's a neurological case, you will get the surgeon who's a neurosurgeon, or in other cases, then you get the specialist there attending. Incision is made on the abdomen. They get an ultrasound. Someone who is specialized in ultrasonography of this type comes in, the exact position of the child and where the incision, the pathology is accessed using a specialized ultrasound. That exact place is brought to the fore, and then a small incision is made. The surgery is done exactly at that point, at that area, and everything is sewed back with minimal incision on the uterus. Now, there are challenges that may occur with these fetal surgeries, and this include techniques used to prevent preterm labor, maintenance of maternal hemostasis in the face of prophylactic agents, because definitely all those interventions cause uterine contractions. They can stimulate uterine contractions. And of course, we need to use prophylactic agents, but these have some complications, that's adverse effects on the homeostasis of the mother. Then maintenance of fetal homeostasis that might be affected also by the affected maternal homeostasis, and the fact that the child also is being operated on. There are some challenges that might arise from even its own homeostasis, and provision of fetal analgesia during surgery. Now, this is a picture just showing anesthesia for surgery. And there are many indications, like I said, as we can see, the child is still within the uterus there, and they are trying to, and you can see the big sacrococcygeal tumor there, or yes, that's just there. So they've exposed exactly where they want to operate on, while still the other parts of the child are still within the uterus, and we can see the cord there, the umbilical cord there. So indications include hydronephrosis, hydrocephalus, sacrococcygeal teratoma, and meningomyelocele, diaphragmatic hernia. Those are some of the indications for fetal surgery to improve the life of the child before the child is born. And also the child can develop further in utero before it's born. Now, in conclusion, significant number of women undergo anesthesia and surgery during pregnancy for non-pregnancy related indications. It is essential that the anesthetist understands thoroughly the implications of physiological and pharmacological changes that characterize the 3 trimesters of pregnancy. A multidisciplinary approach is essential for adequate standard of care. Perioperative care should be planned carefully to ensure the safety of both the mother and fetus while preserving the pregnancy. Fetal monitoring should be done once viable. Regional anesthesia should be given whenever applicable. These are my references. Thank you very much for listening, and we can take your questions after this. Thank you very much.
Okay. Thank you very, very much, Dr. Aderonke, for this very exhaustive presentation. You have indeed gone to town with these 2 subjects. And by way of summary, I would say that you have dealt with the changes of physiological changes in pregnancy, anatomical changes, pharmacological changes, telling us that pregnancy is not an abnormality, but that it is very crucial to appreciate these changes so as to know how to give them the best management for improved outcome. And now coming to the issue of anesthesia for patients with coming for non-obstetric surgery who are pregnant, you have given us the essential principles for management of such cases, telling us the challenges, and you have also gone into town with fetal surgery and the various indications and the cautions to take. Questions and answers. I will be going through the chat box. But before I do, please, Dr. Aderonke Adesiyan has posted a link for you to answer some questions in. And well, there's a reward for the candidate with the best answers, the best options, and of course, fastest. So please avail yourself of this opportunity. So while we are waiting, I'll just read out some questions which have been placed on the chat box. Somebody is asking that why is there a higher risk of pulmonary embolism in the 3rd trimester? Well, I think she's the same person who also said the has been answered. So I think Dr. Adesh to know is coming to these questions. I have somebody asking, that's Dr. Koji, why do you defer urgent surgeries till after the 1st trimester? And also Dr. Ifezwe is asking that, is there a role for tocolysis in the 1st trimester for an emergency? So let's take these 2 first. Thank you.
Okay, thank you very much for the questions. Let me just give a word concerning the issue on PE being more common in the 1st trimester. So it's common all through, but studies have shown, retrospective studies have shown that it's actually common in the first trimester. The answers or reasons have not really been adduced, but I guess with more research, we'll know why it's particularly more common in the first trimester. Now, secondly, the question on tocolysis in the first, if there is an indication for tocolysis in the first trimester, if surgery has to be done. Now, if you go back to my presentation, I did say that in the first trimester, this is the time when you don't have a viable fetus. So there's really no point giving tocolysis at that point because the child, the fetus is not viable. There's no point doing it. So if the child survives after the surgery, that's fine. But if it doesn't, I think the best thing to do is to just make sure that you avoid everything that is going to cause abnormal contractions and all. You're worried more about a child that is viable. So even though you can do the surgery, you can do all of that, but you shouldn't be too worried because if indeed this child, the mother starts to contract, then the baby has to come out. I hope you understand that train of thought. Sorry, is there any other question that I need to answer? I guess those are the two that came up. Dr. Briggs, any other questions?
Yeah, is there for tocolysis? Well,
hello? So,
I think our network is slow.
Okay. Sorry, can you help me with the questions? Because apparently I can't see them here. I don't know why.
There's a question here. Why do you defer urgent surgeries till after the first?
You've answered the first question says, cancer under, for example.
Okay, let me just answer that question on why do we defer the surgery to second or third trimester. It's for viability, basically. The more mature the child is, the better the chances for the child to survive outside of the uterus. So if it's not an emergent surgery, you can try and push it forward as much as you can. But whenever an indication is emergent, it overrules every other guideline. The mother has to survive. The mother comes first. Thank you.
Thank you, Dr. Adesionyo. The next question is, please, how do you refine or define minimal risk to the mother? For example, can a pregnant woman with breast cancer undergo mastectomy under general anesthesia? What are those things you consider as, how would you define it when you say minimal risk to the mother? Then again, Dr. Bode Lawal said there may be late adverse manifestations of anesthetics and other medications administered during pregnancy. For medical legal reasons, at what time after anesthetic can we say that anesthesia can no longer be responsible for an adverse manifestation? That's at what time will you not say that the anesthetic was not responsible if there was any adverse manifestation? At what time? So if you can take both questions, would appreciate.
All right, so let me take the first question on minimal risk. When we say minimal risk, we are taking into account the type of surgery and the type of anesthesia. For example, you can't do a subarachnoid block for a surgery mastectomy. So that doesn't come into question. So what we are trying to say is you consider the drugs that you are given, which I've outlined, that will cause less uterine contraction and less alteration of the homeostasis or the physiology of the woman. So that's what I mean by minimal risk. considering the surgery that needs to be done, if it's urgent or emergent, like we have said, yeah, we don't have a choice. We have to do it. But we can minimize the risk by considering all those drugs that are less toxic to the mother and then to the child, given the type of surgery that is being done. For example, if you have a lower limb surgery, you don't need to do GA in this woman. You might as well give a subarachnoid block. So that's a minimal risk there. Then if you are doing a general anesthetic, you avoid any drug that has been implicated in maybe causing too much. For example, I spoke about sevoflurane being said to, in low concentrations, being very good for pregnant women. But generally, volatiles too should be reduced. Whatever volatile you're using should be reduced. So that's about that. Then late manifestation. In my talk about teratogenicity, I spoke about the fact that really no anesthetic agent has been exclusively and beyond any doubt proven to cause any congenital anomaly. But having said that, they all are potential teratogens. So what you want to do is you avoid any surgery within the time of organogenesis, which is the first 12 weeks, the first trimester. So if you get a woman that needs an urgent surgery in the first trimester, you want to push it to the next trimester. Or if you can push it till the baby is born, please do. But if you have a patient that has an emergency surgery coming in, we don't have a choice. We need to go in. So we will give the patient, the relatives, the mother, we will take an informed consent, outlining the fact that even though it has not been proven, because these studies have not been done in human subjects, but we all know that they are potentially teratogens, and you cannot say what is going to happen. So if you have taken that informed consent, you are free. So that's how to address that issue. That person cannot hold you liable because you did a life-saving procedure. Thank you.
Okay, I don't know if the moderator is back, Dr. Briggs. Okay, so let me take the other question. Thank you, Dr. Adesionyo, for the explanation so far. There's a question here from Dr. Odigbo Michael. He said, please, I would love a clarification on the slide about ephedrine versus phenylephrine. I guess what are the advantages and disadvantages of both? I guess that's what he's asking. Then another question here said, thank you, ma. That's Dr. Belema Oduma. She's asking, thank you, ma, she said, thank you, ma, for your presentation. How is intraoperative fetal monitoring done? Okay, I guess that must have been explained, but maybe she wants more clarification on that. Then the other question, what are the possible triggers to uterine contraction post-op? This is from Dr. Sani Nihimatali. Sorry if I didn't pronounce your name well. What are the possible triggers to uterine contractions post-op? So if you can take those questions, we would appreciate. Thank you very much, Dr. Adesionyo.
Okay, let me start with the possible triggers of uterine contraction post-op. Number one is pain. That can always cause uterine contraction. Then, because they will release catecholamines that will cause uterine contraction. Then, excessive manipulation of the uterus. Anything that makes you start touching the uterus or stressing the woman out can cause uterine contraction. Then, of course, the other things that can also, well, not really uterine contraction, but can be detrimental to the health of the baby is if the maternal homeostasis is not maintained. For example, the woman is hypotensive or the woman is hypoventilating. All these can also be transmitted into reduction of uteroplacental blood flow and then adverse effects, adverse complications in the child. So that's to that. Concerning, there's a question there about laparoscopic surgery being done for fetal surgery. That was what I explained exactly. Definitely, laparoscopic surgery can be done. And what I explained there is that though it can be done, the incision on the abdomen is an open incision. So they will open up the skin, then they will now introduce, instead of going through a thin, a very small access on the abdomen, they open the abdomen, then they will now introduce the laparoscope into the uterus. That is what they do for laparoscopic surgery in fetal surgery. Then finally, ephedrine versus phenylephrine. If I must go there, what I explained there is that traditionally we believe that ephedrine is the best, but it's been found that phenylephrine actually has better hemodynamic effects when compared to phenylephrine. So definitely, yes, if you have that in your center, it's preferred to use phenylephrine when compared to ephedrine. So I hope I've been able to answer all your questions. Thank you.
Okay. Thank you very much, Dr. Adesiyan. There's a question here, or one last comment from Dr. Job. He's asking, he's actually saying you should try and throw more light on anesthesia for ovum transfer, as it's being reported that some intravenous anesthetics migrate into the ovum in cases of IVF. Thank you. So I don't know if you have anything to say on that issue.
The issue, he said, I think, okay, he said anesthesia for ovum transfer, as it's been reported that some intravenous anesthetics, yes, migrate into the ovum in cases of, yes, you see, like I said, there's a lot of controversy in this area of fetal surgery or transfer of anesthetic agents, either, well, here at the transfer of the ovum or during pregnancy. I think the thing to go away with is any anesthetic that is being given during pregnancy is potentially deleterious. But we need to understand that there's a baseline tendency for every pregnancy to result in congenital anomaly. And that I explained, about 3% of patients or of our population or fetuses will have congenital anomaly, whether they had an anesthetic or not. So with the background knowledge of that and the fact that you will try as much as possible to avoid using anything that is not required, you will take a proper consent. And this consent will be exhausted, so that there is no issue about the person was not warned ahead of time, because really nobody knows for sure what will happen when these things, like I said, all research that has been done in animal models. So that's all we have to work with. It's unethical to do it, except maybe we now begin to conduct retrospective studies on people that had anesthetic at this stage, maybe people that have ovum transfer. What is the incidence of congenital anomaly when they have certain types of anesthesia? So otherwise, we don't have data to support the fact that for sure the anesthesia was what caused the congenital anomaly. So that's my answer to that question. Thank you.
Okay. Yeah. Okay. Yeah. Thank you very much, Dr. Adesiyan. I think most of the questions have been dealt with on the chat box. I don't know if the moderator is back, Dr. Briggs. Dr. Brisma. I think she's back.
I'm back. Can you hear me?
Okay, yes.
Hello, can you hear me?
Yes, we can hear you, ma'am.
Hello, can you hear me? Okay, yes, thank you very much for the bailout, Dr. Okoje. Thank you for bailing me out. And thank you once again so much to Dr. Adesiyan. I will now hand over to the president, Professor Bolinwaso.